Hello, welcome and kumusta, and thank you for joining me. This is Hao, your occupational therapist, and welcome to Occupational Therapy Conversations. Today, I managed to get hold of their position statement regarding occupational therapists' role in the practice of critical care, and this position statement covers across the lifespan. This is interesting and exciting because it is the position of occupational therapy, it is the position of the profession, it is the position of the body, the professional body, and it covers not just critical care in one area, but it is across the lifespan. So I would recommend that you guys grab hold of this document, and you can get it from the American Journal of Occupational Therapy, November to December 23 edition. It's volume 77. In comparison to where we are in the United Kingdom, our professional body does not have a position in this matter, and there will be some ICS or Intensive Care Society position on that one. But in comparison, the occupational therapy statement in where we are at the moment in the United Kingdom is so weak as compared to this position that they have across the pond, and it's really worth the read. So what this document is stating is that the American Occupational Therapy Association affirms that occupational therapy practitioners are essential interprofessional team members who address the needs of those people who are critically ill across the lifespan. So we are there, we are needed. The scope of practice of OT provides a holistic lens that is required to best implement an evidence-based critical care guidelines to aim to improve the quality of survivorship. So if we're looking back at this statement here, it's not just survivorship of patients, but it is the quality of the survivorship. That is where we could come in. Occupational therapy is practitioners. We facilitate early engagement and rehabilitation. So that is our role in critical care. Early engagement and rehabilitation, which mitigate the severity of the conditions acquired in an intensive care unit, right? So we don't have an intense influence, but we are there. And what we do is we are there to facilitate early engagement and early rehabilitation. This is like what I've always been saying. Anything you do, anything we do matters and has an outcome. So if you're there and you start talking to patients, and if we're there and we start engaging with the patients, doing something that can get them out of the rut, then we can contribute and we can mitigate the severity of the conditions. And what are some of those conditions that are acquired in intensive care unit? Delirium, weakness, skin injury, post-ICU syndrome. These are some general conditions that we will encounter. So it is suggesting that early initiation of critical care rehabilitation, and this includes occupational therapy, has been shown to reduce the ventilator days. It has been shown to improve functional outcomes and decrease length of stay. This was done from the works of Costigan et al. In 2019, Higgins et al. In 2019, and Schwickert in 2009. Occupational therapy practitioners bring added value to critical care teams and health systems by reducing the hospital readmission risk through discharge planning and pre-discharge intervention as well. What's nice here is that the association, American Association, asserts, wow, such a comforting and reassuring statement by the profession, isn't it? AOTA asserts that occupational therapy practitioners play an integral role on the interprofessional critical care team. And also, this position statement defines the distinct role and value of occupational therapy practitioners in critical care settings across pediatric and adult populations. So this is very good, because if you want to know what the roles are, what your roles are. You don't have to do any guesswork. A huge body of work's already been done by a huge amount of occupational therapists in the United States. And I am so jealous of how strong their profession is, how strong occupational therapy profession is across the pond. So the paper is stating that in critical care setting, it differs from general acute care setting because the occupational therapy practitioner, so when you're practicing in critical care, you must understand how your intervention will interact with some invasive medical therapies. So that's how it differs really. It's all about the intensive Medicare or intensive medical intervention. And when you say intensive medical intervention, what do we mean by that? What are these intensive medical intervention? So critical care it's a medical specialty, just for everybody's awareness. Critical care, medical specialty, and this involves treating seriously ill patients who are experiencing critical illness or who are recovering from critical illness or a life-threatening condition. And because it is such a life-threatening condition, it really needs an intense critical care unit. So how would a person survive medical illness, or how would people survive critical illness? To do this, when it comes to critical care medicine, it requires invasive medical therapies. And what are these invasive medical therapies, you may ask? This can be continuous medication infusions. Yeah, things that get medications that gets pumped into the body straight away. It can be artificial organ support. So an organ support would be like, for example, dialysis would be an organ support for the kidney. You can have ventricular assistive devices for the heart. You can have extracorporeal membranous oxygenation for the lungs as well. And these are most of the organ support or artificial organ support. And invasive medical therapies can be after the surgery. And what happens is, because we are constantly monitoring the patients, there is a need to frequently assess the state of the body. So it's intensive monitoring. And it's not just the physical state on the outside, but intensive monitoring of what's really happening inside. And what's happening inside can be measured and can be looked at by looking at the parameters and the chemistry that's happening, the blood supply, the blood gases and things like that, the amount of acidity. So when we're talking about the critical care team, this is a group of trained healthcare professionals who work in the intensive care unit. And they can be, who are the people that we're working with in critical care? You can have physician intensivists. In the States, they call it physicians, but in here, it can be intensivists. You can have critical care nurses. Occupational therapists should be there. We should be there all the time as well, along with our colleagues, the physiotherapists, speech and language therapists. We have pharmacists, dietitians, social worker can be in there as well. And then there are some advanced providers like advanced workers or advanced nurses, advanced practitioners like nurses, or there are specialist assistants as well, particularly if they're focused on managing and operating these supportive organ devices. For example, early rehabilitation, including mobilization and early engagement, is the fundamental facet of occupational therapy in critical care settings. This is so nice because it's highlighted that yes, early mobilization, and that's what's always been promoted in the United Kingdom. Early mobilization has always been the key. Yes, but we step back as occupational therapists because early mobilization is a thing that our colleagues, the physios, have already owned. It's always been accepted that physios are doing early mobilization. Also, the nurses are also doing early mobilization by getting them out of bed. But for occupational therapists, the early engagement, that is the key. Early engagement is a fundamental facet of occupational therapy. When we are saying early mobilization, it involves assisting the patient who's very ill into an upright and out of bed position. Early mobilization does not necessarily mean walking. It just meant we need to get the person in an upright position. It's very simple, but it is labor intensive. There's a lot of things that you consider, but the principle is so simple. All you need to do is get the person in an upright or out of bed position. Now, you get the person in an upright and out of bed positions when they are still connected to multiple organ support systems. And it can be ventilators. You can sit a person if they're on ventilators as long as they're awake. You can get them in sitting out even if they have dialysis, as long as they're awake. And even if they have cardiovascular support, as long as they're awake. So the key to early mobilization is you need a person to be awake, to be alert, to start to engage, to start to participate. Now, early engagement then will involve providing critically ill patients opportunities to participate on meaningful, client-centered, goal-directed occupations in critical care settings. Yeah, this is our area, guys. Early engagement. Engage in purposeful, meaningful, client-centered, goal-directed occupations. Yeah, personal care of brushing, combing hair, yes, that's that. But if they cannot do that yet, anything, as long as they're engaging on something, it can be meaningful. You can do something. You can do games. You can do some enabling activities, because these are all preparatory activities. These are all goal-directed activities. The old school called enabling activities. All those pegs, all those cones, all of those stacking activities, you can do that. Yeah. So early intervention or early engagement can precede early mobilization if the patient is medically unable to transition to an upright position. Beautiful, isn't it? It is so calming and it is humbling as well. This is what I've been saying all along. Early mobilization, early engagement. This is going to be our outcome. Now, it's stating that delirium is also a factor in here. Delirium is really becoming very popular. By definition, in this paper, delirium is a sudden change of the mental status. It is commonly found in ICU patients, and it is significantly associated with increased mortality. Yes, obviously. And it is associated with increased ICU length of stay, increased days on mechanical ventilation. There's lots of healthcare expenditure on this, especially if they're paying for it. But in the United Kingdom, people are not paying for it. But the longer they stay in critical care, the longer that the government is paying for this, because this is free at point of delivery. And there is more and more prolonged physical and cognitive, long-term physical and cognitive impairments. So what we do obviously is prevention. How do you prevent delirium? Early engagement. Your routine screening. Yes, it's a straightforward. You don't have to screen. Just have a look. If they're drowsy, hypodelirium. If they're combative, hyperdelirium. If they're confused, delirium. Everything is delirium. So early routine screening already, that these people who are recovering, they're already delirious. That's the definition now. And we need to provide a patient-centered intervention that are key aspects of delirium prevention program. There has to be a program. All there is, just engage, provide music, provide visual stimulation, provide auditory stimulation, get them to interact. How would they interact? They may have to interact with us. They may have to interact with people around them, with family. The more you interact, the more, that's the therapy. Talking itself is therapy. Invasive medical therapies, what are these things? They encompass medications, advanced devices, It involves procedures that critical care providers use to stabilize and manage critically ill patients. And these invasive medical therapies are, there's a lot of them, and they can be ventilators. Yes, very usual, popular one. Most critical care around the country has ventilators. Continuous renal replacement therapy, and this would be the filters. Yes, again, these are all invasive because it involves getting through the body. Extracorporeal membranous ECMO, and in the United Kingdom, there's about 8 now, I believe, ECMO centers. And it is invasive, yes, because it pokes through the body. And you have external ventricular drains, or EVDs. You can have central venous catheters, arterial lines, and many more. So there's a lot more of these invasive medical therapies that we are providing in critical care. Now, with pediatric intensive care units, or the PQs, they provide specialized care for children up to the age of, in the States, it'd be 21, but in the United Kingdom, it'd be up to 16, I believe, or 18. I can't remember. But anything less, imagine that a teenager is almost grown up. It's almost an adult, isn't it? So it's still intensive care and it's still critical care. Yeah. So that's just the definition. So pediatric ICU, that's what that means. In contrast to that, the neonatal ICU would be intensive care units that provide specialist care to premature and newborn infants. Just those are the definitions of different ICUs. Neonatal, yes, infants, those were preterm babies, right? And you can have pediatric ICU and then grown up and adult ICU. Okay. Now, you would hear in critical care, there is this post-intensive care syndrome, PICS. And this is very popular again. All these new terminologies that are coming out. It's a syndrome. It's a lot of things that are happening at the same time. Sin is combined, associated symptoms with the condition. So it's a syndrome. And these PICS, this is a combination. It's a lot of problems. It's a constellation and a combination of cognitive, physical, emotional symptoms that are persisting beyond a person's discharge in ICU. Yeah. With OTs, we're already there on 3 out of 3 areas. Perhaps in the United Kingdom, we may not think that we are overly involved on the physical improvement of the patient. Yes, maybe there's something that we're sharing with our colleagues, the physiotherapists, on the physical side. But where occupational therapy's strength lies, it lies on the cognitive side of things. It lies on the emotional symptoms. Yeah. So you have to wake up the mental health training that you had, if you had, and you should have had. As occupational therapists, the mental health training is as important as the physical retraining, because in physical retraining, cognitive is also part of the physical retraining. There we go. So that is our definition of critical care in occupational therapy in critical care. And I hope you just had a very quick gist of the things that we can be involved with. And I just talked about the definitions. Now let's move to the importance and significance of occupational therapy, of where we are, or of the practice. So with critical care and with ICU, so ICU is just part of the healthcare process, and this is a proper acute condition, and it admits a lot of populations, so heterogeneous population of patients. And what it happens is that they really do need an intensive clinical assessment, and it's very complicated. So with OTs, we can work across the lifespan, and we have a key role in facilitating occupational participation while the person is in and even after they've been admitted to ICU. Technically, all people who've gone to ICU should have had occupational therapy input. So it's a must. So if we're in a surgical facility where the main clientele is coming from the ICU, technically everybody should have had that. But in critical care, we are integral in facilitating occupational participation. Okay? And what happens to people who's been admitted? We need invasive or they needs intensive monitoring in critical care. There's a need for supportive airway, breathing, circulation, lots of these things. So when it comes to the mortality rate, the overall, and this would be more on statistics across the pond, yeah. A mortality rate for those people admitted to ICU, it ranges from 10 to 29% in adults and 2 to 6% in children. Although those people with a lot of problems, the frail people, those people who are frail, they're at a higher risk of critical illness, and there is a higher degree where they would suffer from long-term sequela of being admitted in critical care. So early initiation of rehabilitation, and this includes occupational therapy, it has been shown to be effective in improving people's long-term status. It improves clinical outcome. We help in the contribution. We are influencing the length of stay. Now, fewer than 10% of patients on ventilation or more than 4 days, return. This is for your information, everybody. Those people who are in ventilation for more than 4 days, about 10%, fewer than 10% of them return to a complete functional independence after 1 year. So there is a factor here. There's something that we need to keep an eye on. And half of the critical illness survivors, they continue to require caregiver assistance in some capacity 1 year after they've been discharged. This is especially true for those people who've just been unwell. They've just deteriorated so badly, particularly for those ECMO patients. Yeah. So half of them almost and still require carers or support one way or another. Now, with our lens, because we're using a client-centered lens, we can both assist patients in achieving their functional goals and provide individualized carer training to make transition in home faster and more successful. Now, this is more true for the practice in the United States rather than in the United Kingdom. Because in here, once a person's left our team, that's it. If I'm working in critical care, once they go to the wards, it's up to the people up in the wards. And once people there in the wards, they go pass it on to the community. Whereas there are other practices, I believe there are some centers in the United Kingdom where OTs hold a clinic where they choose to ask a person to come back and they hold their clinic. And we can do that. That's an option for us, guys. We are professionals. That's an option. Now, for those people who have survived, the return to employment is usually associated with improved health quality of life and fewer depressive symptoms. Unfortunately, those people who's been in ICU, the prevalence of them returning to work is around 36% at 3 months. Around 60% would probably go back to work after a year, and 68% at around 42 to 60 months. And for those who work up to 36% and for those who return to work, up to 36% endured job loss, 66% were faced with a change of occupation, and around 85% reported that they are working in fewer hours. To meet the needs of ICU survivors, institutions and places are establishing post-ICU recovery clinics, and occupational therapy practitioners have an opportunity to harness our entire scope of practice to facilitate resumption to occupations, which include work. Just remember this, guys. For those of you who are listening, practicing in ICU, don't limit yourself to the things that are being dictated by the area. We are in control. We can decide to have clinics If we need to do that, we just need to do and speak, and we shouldn't be covering or be shielding behind the fact that there is no time. We need to make time. And if there is no time, we need to find ways on how we can do that by instigating a service improvement initiative or as a research. So it's going to be a long-term thing, but at least if it's funded by research, then there is some funding that would be available. So now let's look at the contextual factors that influence occupational performance. So occupational therapists like us, we play a key role in evaluating the impact of ICU contextual factors in occupational performance. And we have an impact in recommending environmental modifications to facilitate patient participation. This is particularly when they're out in the community. Yes, that's true. Individuals then who are experiencing life-threatening illness with severely altered body system and functions intrinsically face occupational disruption and disconnection with valued roles and routines. Of course, when somebody is sick, they're ill, there is an interruption in their routines. Now, with critical care medicine, they have historically included routine sedation and routine immobilization of patients, unnecessarily restricting active occupational engagement and hindering recovery outcome. So in practice, once you're walking down in critical care, ask the nurse, are they in sedation? They're not. They're asleep. Wake them up, engage them, get them to do something. That's your therapy. If they become combative, they will then do something. They will put some pharmacological intervention to manage this, and you're going back down to zero again. So do not wait for referrals. If you're in critical care, you're in critical care. Be involved, be part of the team. Take charge, be proactive. The ICU's physical environment, it also inherently disrupts occupational participation because it's very sterile. It is designed for people to monitor their condition. So it's very sterile. It's just like an operating area. It's very clinical. Lots of tubes, lots of pipes. So the other thing that's adding contextual implication to a person's engagement would be again the clinical area. Sometimes it's bright and it disrupts the sleep. It's very noisy. There is restricted family visitation, and it prevents patients' full participation. It stops them from being autonomous. And how is a person going to be autonomous? Just by being awake and just talking and just deciding what they want to do throughout the day, factoring in the limits of the bed, of the monitor. You sit them down, partially sit them down. And then you say, what do you want to do? What do you want to watch? You want to listen to anything? You can ask these things. And you're promoting a self-determination when you do this. So when it comes to common areas, so in general, the common areas for occupational therapy intervention, the common occupational therapy in critical care settings would be this. And in this document, in this position statement, it is highlighting some of that, the very common areas, like the intervention area of environment. We can influence the environment. We can maximize natural lighting. We can identify physical and sensory aspects of the critical care environment, change it, control the lights, control the sound, stimulate or make it more inducing. People are always busy. Nurses are doing that. They're attempting to do that. But with OTs, maybe we can help a little bit more. It's not a lot, but we're contributing. Contributing. Sleep is another thing. So we need to support normal sleep and wake cycles. You can't do this alone. This is going to be very challenging for an OT, especially if you're not there all the time. But you can perhaps do some relaxation activity or teach people to do relaxation prior to them going into bed, or stimulate them throughout the day so that they'd sleep better at night. Sleep is an area. Delirium, yes, very popular. You just have to identify the best practice guidelines to reduce the risk of delirium. Basically, normalize the sleep pattern, provide frequent reorientation. You have to minimize the sedation, encourage family visitation and contact because they will be more awake once family is there. You can and we can implement ICU diary, and we better start considering doing this as a staple for all of us. We need to promote the use of existing corrective lenses, so get them to wear glasses, the hearing aids, dentures, and implement cognitive engagement activities. There we go. So it's the implementation of the engagement doing. Sensory motor retraining. So we need to address the weakness, sensory deficits, because this will all be in preparation for their future ADL retraining. It will combat polyneuropathy. You can provide therapeutic activities. You can get them to engage with ADL participation, transfer training if it is possible, right? And for children, provide opportunity to improve their body awareness, for example, and self-regulation. How do you do that? And then you get them to feel. This is sensory integration training. Yeah. Tactile stimulation, receptors, you're stimulating that. And for us, and for my training in my unit, I call this the component restorative program. Sensory motor retraining. This is performance component restorative program. And it is also added in my recovery monitoring program. I call that recovery monitoring program. Now, neurocognitive aspects, we can do that. We need to screen neurocognitive changes. If there is a problem, we can provide temporary compensatory strategies. We can start education, refer to an outpatient follow-up if it is required. Yeah, neurocognition. Again, this would be for my neuro retraining program in my center. Okay. ADLs is something that we can be involved with, particularly if the critical care is not intensive critical care, but they're probably just there for they're there for like high flow, non-invasive ventilation, for example, or if they're there because of a renal replacement therapy. People are okay if it's they should be okay and they should be doing something. So ADLs, this is interesting. Feeding and swallowing. In the United Kingdom, feeding and swallowing is not the position of occupational therapy. It's something that occupational therapy does not do. But in the States, it is something that occupational therapy does. So my training involves us as occupational therapists learning how to do dysphagia management. That is something that we do. That's something that we did. I have a colleague who's American and was trained over in the United Kingdom, and she wanted to practice in the States, but she cannot sit on the state examination because they were saying that her training in the United Kingdom is not at par with the training of the occupational therapist in the States. So this is a gap for us guys, and at some point there's going to be a call. I'm going to start the call for OTs to learn how to do with the dysphagia so that we can keep up with international practice of occupational therapy. And it is about time. That's going to be a long-term project. So feeding and swallowing. Leisure and play, we can do that, especially if we're working with children. But then leisure and play does not limit it's not limited to a person's age. Leisure and play can happen even when people are grown up. So we can do that as well. Social participation. We can encourage social participation with the providers and engagement with friends and family through the visitation and incorporate family in the treatment plan. So I remembered when I was doing some of the sessions that I had with patients, I was setting things up with my patient, and it involves having the husband in. And the husband and the patient will play some kind of an air hockey on the iPad together. They were doing that. They were doing coloring together. I time my session when the husband is in so that there is a better interaction with them. Social participation is there for us to do. Neuromuscular education, again, this is part of the sensory motor retraining. When you have used progressive activities, building trunk control and balance. Again, this is where we share it with the physiotherapist. This is why people think that OTs and physios do the same things. Yes, we do, but on this particular aspect only. Help patients progress from supported sitting positions to unsupported sitting positions to standing. We can do this. It is in the scope of occupational therapy. How else can you start to engage on day-to-day things if you do not have that trunk control? We can. Yes, we can. We can facilitate weight bearing on the upper limb, provide coordination retraining using other modalities. And this is what's interesting. OTs in the United States can use modalities such as functional electrical stimulation, vibration, physical agent modalities. It's been around since the 90s. Transfer and mobility training. Yes, we can do that. But to do that, you need to have the skill. You need to have the confidence to do it. Yeah? Don't be scared. You are professionals. We're occupational therapists. We can do this. Social and emotional support. So we need to routinely screen for signs and symptoms of depression, anxiety, other mental health concerns. We need to monitor for difficulty with coping. We need to foster coping skills. How do you foster this? Through engagement, through facilitation, by allowing a person to be successful in little things, little activities that we design and that we can provide to our patient. We need to refer a patient for an appropriate mental health providers as required. But this is part of a team. So we can have the doctors do that, but we can highlight it definitely. And then one last thing would be a musculoskeletal and skin injury prevention. Again, this is soft tissue integrity. We recommend the appropriate bed surface. Again, a role that's taken over obviously by soft tissue and tissue viability nurses. But then we can, because health maintenance is an occupational therapy concern. It is one of the ADLs. Manage edema. Simple. It is there, part of the health maintenance. You consider using orthotics, cast for joint protection, non-pharmacological management options as well. So how do you manage this? Doing relaxation techniques, any other techniques that you can utilize that will not use pharmacy. Okay, guys? So this is the scope. These are the contextual factors. These are the things that we can be doing in critical care, right? I hope you get pumped up by this very short talk, which is about running almost an hour now. So I'm going to cut it down up to this, and then we'll have further conversations about this. But this is occupational therapy in critical care, and this is us reviewing the AOTA's position with regard to occupational therapy and the practice of critical care, OT practice in critical care medicine. I hope you learned a little something today. I hope this gives you a little spark of inspiration. It gets you kick-starting on the come on, let's do this. Okay, guys, until next time, bye. If you enjoyed this podcast, talk to your friends and colleagues about it. Like it, subscribe, share, and do what you can to appease whatever algorithm that is at play. Just remember, guys, anything you do matters and has an outcome. Until next time, bye.